Welcome back, everyone, to the deep dive. Ready for another fascinating deep dive?
Always.
Excellent. Today, we're going to be tackling TSH-secreting pituitary adenomas.
Ooh.
Those are a mouthful.
Yeah.
So those are rare pituitary tumors that actually secrete TSH, which is thyroid-stimulating hormone.
Yes.
So get this, these things actually cause hyperthyroidism,
That's right.
but not in the typical way, so this should be fun. We've got a great medical text excerpt to guide us through all the details.
It's a really interesting one.
Yeah, you're in for some really surprising facts, so buckle up.
Now let's go.
Okay, before we get too deep into the weeds with these tumors, I need a little refresher course.
Okay.
Remind me, where is the pituitary gland and what does it normally do?
So picture this. It's a tiny pea-sized gland
Okay.
right at the base of your brain.
Okay.
That's the pituitary. And its job is to basically conduct the orchestra of hormones in your body.
Wow.
Things like growth, metabolism, reproduction.
It's doing a lot.
It's all influenced by this tiny powerhouse.
Tiny but mighty.
Yeah.
Okay, so we've got these rare tumors setting up shop in this crucial spot. Just how rare are we talking?
So hold on to your hats,
Okay.
because TSH-secreting pituitary adenomas account for less than 1% of all functioning pituitary tumors.
Wow.
And as a cause of hyperthyroidism, even rarer.
So it's like finding a needle in a haystack.
Exactly.
So doctors really have to be on their A game to spot these things.
Absolutely. It's a real diagnostic challenge. They have
Yeah.
to be like detectives,
Yeah.
piecing together clues, because this condition can easily be mistaken for other, more common types of hyperthyroidism.
Right, right. Okay, so we've got this rogue factory pumping out TSH.
Yeah.
What's the effect on the thyroid itself?
So it's like the thyroid is getting constant frantic orders
Uh-huh.
to produce more and more thyroid hormones,
Oh, wow.
even when the body doesn't need them. That's what leads to hyperthyroidism in this case.
Okay, and this is where it gets really interesting, right?
Yes.
Because normally, if the thyroid is already in overdrive, the pituitary would try to calm things down by lowering TSH.
Exactly.
But that's not happening here.
That's not happening here.
It's ignoring all the signals.
Exactly. The tumor is calling the shots,
Wow.
ignoring the body's feedback mechanisms.
And so just to add another wrench into this whole thing,
Yes.
I hear that TSH levels in these patients can be all over the map.
All over the place.
Some might have normal TSH levels despite being hyperthyroid, while others have sky-high levels.
Yeah, you can't just rely on one blood test.
No.
It's like a medical puzzle.
Yeah, you really have to dig deep. Okay, but let's talk symptoms.
Okay.
What should people be looking out for?
So many patients experience the classic hyperthyroidism symptoms:
Okay.
rapid heartbeat, weight loss, sweating, anxiety.
Okay, those are the usual suspects.
Yes.
But I hear there's a twist.
Oh, there's a twist, all right.
Okay.
Some people have very mild symptoms, or even none at all.
No symptoms.
This is where it gets tricky.
Yeah.
Someone could be walking around hyperthyroid for years without realizing it.
So this is why early diagnosis can be so difficult.
Exactly. We've seen cases where the tumor was only discovered incidentally years after symptoms first appeared.
Wow, that's a little scary. I don't like that.
Yeah,
Okay, so even subtle changes in your body, you got to be paying attention.
exactly.
Okay, but aside from those usual suspects, those hyperthyroidism symptoms, are there any other red flags that might point to this specific tumor?
So almost everyone with this type of tumor develops a goiter,
Okay.
which is an enlarged thyroid gland.
Okay.
That's because it's constantly being stimulated to grow.
Right, because it's getting those signals to keep producing.
Exactly.
Okay, but what about symptoms that are specific to the tumor's location?
Right.
Remember, this thing is hanging out right at the base of the brain.
You're right. That location has some interesting consequences.
Okay.
About 40% of patients experience vision problems
Vision problems. Oh, no.
because the tumor can actually press on the optic nerves.
Not good.
No.
Anything else?
So for women, the tumor can also cause menstrual irregularities
Okay.
and even lactation,
Lactation, wow.
regardless of whether they've recently given birth.
So that just adds to the mystery of everything.
Yes.
Okay, so how do doctors even begin to unravel this puzzle? What are the first clues they look for?
So it all starts with blood tests,
Okay.
specifically thyroid function tests.
Okay.
They'd be looking for high levels of T4 and T3.
Okay.
Those are the thyroid hormones,
Okay.
along with a normal or high TSH level.
So that's the first big clue that something's off.
Yes, because in most cases of hyperthyroidism, you would expect the TSH to be low
Right.
because the pituitary usually tries to rein things in
Uh-huh.
by lowering TSH.
Right.
But remember, with this tumor,
Yeah.
it's a whole different ballgame.
Yeah, it's calling the shots.
Exactly. The tumor's churning out TSH no matter what
No matter what?
the thyroid hormone levels are.
Wow. Okay, so that unexpected lab result,
Yeah.
that's a red flag.
Yes.
What happens next?
So there's another blood test that can help.
Okay.
The alpha subunit test.
Okay.
Think of it as a bonus clue.
Okay.
It measures a component that's found in several hormones, including TSH,
Okay.
in people with this tumor.
Mm-hmm.
The levels of alpha subunit are often elevated,
Okay.
especially in relation to TSH.
Okay, so it's like another piece of the puzzle pointing toward the pituitary.
Exactly.
Does that mean it's time for imaging?
Yes, an MRI of the pituitary would be the next step
Okay.
to actually visualize the tumor and confirm the diagnosis.
Okay, so we see a tumor on the MRI, case closed, right?
Not quite.
Oh no, what else could it be?
There's a wrinkle called incidentalomas.
Incidentalomas.
These are harmless little spots on the pituitary
Oh.
that can show up on an MRI, but aren't actually causing any problems.
So you could have a spot on your pituitary and not even know it.
Exactly.
How common is that?
More common than you might think.
Really?
Studies show that incidentalomas are found in up to 10% of the population.
Wow, that's a lot of people walking around with pituitary spots.
It is.
Okay, so how do doctors tell the difference between an incidentaloma and a TSH-secreting tumor?
That's where the combination of blood tests and imaging comes in.
Yeah.
If someone has all those telltale blood test abnormalities
Okay.
and a visible tumor on MRI,
Okay.
it strongly suggests a TSH-secreting pituitary adenoma.
Okay.
But even with all that evidence, doctors still need to rule out other conditions
Okay.
that can mimic this tumor.
Like what?
We'll get into that next time.
Oh man, talk about a cliffhanger.
I know.
All right, well, join us for part 2, where we will continue to untangle this medical mystery.
Looking forward to it.
See you there.
All right, so remember where we left off.
Yeah, we were just starting to talk about other conditions that can mimic these TSH-secreting pituitary adenomas.
Right, and one of the biggest culprits is resistance to thyroid hormone.
Resistance to thyroid hormone.
It's like the body's tissues, including the pituitary, are playing a game of telephone with the thyroid hormones.
Okay.
But the message gets garbled along the way.
So it's like they're not getting the message.
Exactly.
Okay. So RTH messes up the body's response to those hormones. But how does that end up looking like a TSH-secreting tumor on those initial blood tests?
Well, both conditions can present with high T4 and T3 levels.
Right.
And a normal or even high TSH level.
So it's tricky.
Very tricky. So doctors have to dig deeper
Okay.
and look for subtle but crucial differences.
All right. Detective hats on.
Yes.
What are the key clues that distinguish these two conditions?
So one clue is the level of a protein called sex hormone binding globulin, or SHBG.
SHBG. Okay. What's the significance here?
So it's produced in the liver and is influenced by thyroid hormones.
Okay.
In people with a TSH-secreting tumor,
Yeah.
SHBG levels are usually high
Okay.
because their body is being flooded with those thyroid hormones.
Right.
But in people with RTH,
Yeah.
SHBG levels are typically normal
Interesting.
because their bodies aren't responding properly to those hormones.
So it's like their bodies are ignoring the flood.
Exactly.
Okay, so that's one way to differentiate them. What else?
Well, remember the alpha subunit test,
Yeah, that bonus clue.
that bonus clue. It comes in handy again.
Right.
In RTH,
Okay.
alpha subunit levels are usually normal,
Uh-huh.
whereas in TSH-secreting tumors, they're often high.
Okay, so that's another point for the tumor.
Right.
Any other tests that can help clinch the diagnosis?
Doctors might perform a TRH stimulation test.
TRH stimulation test. Okay, remind me what's that?
So they inject a small amount of TRH,
Okay.
which is the hormone that normally triggers the pituitary to release TSH.
Okay,
So it's like sending a special delivery message
got it.
to the pituitary.
I'm guessing the pituitary's response, or lack thereof, tells us something.
Exactly. So in people with RTH,
Okay.
the pituitary is still sensitive to TRH.
Okay.
So their TSH levels will rise after the injection.
So it's working like it should.
Exactly. But in people with a TSH-secreting tumor,
Yeah.
the TRH injection won't have much effect
Okay.
because the tumor is already producing TSH on its own.
It's like the pituitary is saying, thanks, but I got this.
Exactly.
Wow. Okay, so it's all about how the pituitary responds to that TRH trigger.
Yes.
Fascinating. What a wild ride we've been on just trying to figure out the diagnosis.
It's true. Diagnosing these tumors can be quite the adventure.
Yeah.
But once we've cracked the case,
Uh-huh.
the next question is, how do we treat it?
Okay, so the diagnosis is in. What happens next?
The primary treatment is surgery.
Okay.
specifically a procedure called transphenydoidal resection.
Transphenydoidal, that sounds kind of intimidating.
It's actually less invasive than it sounds.
Okay.
Surgeons access the pituitary gland through the nose.
Through the nose.
Yes, rather than opening up the skull.
Oh, that's way better. Okay, but even with this fancy technique, are we guaranteed to get rid of the troublemaker?
Sadly, no.
Okay.
Think of it this way. Surgery is like the first line of attack, and it works about 1/3 of the time.
1/3. Okay, so what about the other 2/3?
For the rest, we need backup.
Backup. Okay, so surgery isn't always a cure-all.
Right.
What's the backup plan?
That's where medication steps in.
Oh.
There are a couple of options that doctors can use to manage the condition.
Okay.
One option is dopamine agonists.
Dopamine agonists. Now, aren't those often used to treat Parkinson's disease?
They are.
What are they doing in this context?
So they can also be effective in controlling hormone production.
Okay.
And some pituitary tumors, including TSH-secreting adenomas.
Oh, interesting.
They basically trick the pituitary gland into thinking there's enough dopamine in the system,
Okay.
which helps reduce TSH production.
It's like a sneaky way of calming the tumor down.
Exactly.
Are there any other medication options?
Yes, another effective medication is octreotide,
Octreotide. Okay, and what is that?
which is a somatostatin analog.
Somatostatin analog. Break that down for me.
So think of somatostatin as a natural peacekeeper in the body.
Okay.
It inhibits the release of various hormones,
Oh.
including TSH.
Okay.
Octreotide is a synthetic version of somatostatin
Got it.
that's longer acting and can be given as an injection.
Okay.
It essentially acts like somatostatin,
Uh-huh.
binding to receptors on the tumor cells
Okay.
and blocking the release of TSH.
So it's like sending in a decoy to quiet things down.
Exactly.
Is it effective?
It is. Octreotide is quite effective.
Okay.
And it can even shrink the tumor in some cases.
That's encouraging, but I imagine like most medications, it comes with some potential downsides.
You're right, it can cause some side effects like nausea, abdominal discomfort, and diarrhea.
Oh, no fun.
And it's also quite expensive.
So it's a bit of a trade-off.
Yes.
Powerful medicine, but with some potential downsides.
It's always about weighing the pros and cons,
Right.
finding that sweet spot for each person.
Yeah. And I imagine it's very
Individualized.
Okay, so important to remember, though, there's one type of medication that's absolutely off limits for treating this condition.
Yes.
Anti-thyroid drugs.
Correct.
Why not? I mean, aren't those the standard treatment for most cases of hyperthyroidism?
So here's the thing. Anti-thyroid drugs work by blocking the thyroid gland's ability to produce thyroid hormones.
Okay.
But remember, in this case, we've got a tumor
Yeah.
constantly pushing the thyroid to make more hormones.
Okay, I see where this is going.
If you block the thyroid,
Uh-huh.
the body freaks out,
Yeah.
senses a drop in thyroid hormone levels,
Yeah.
and sends even stronger signals to the pituitary
Uh-huh.
to pump out more TSH.
So it's like a vicious cycle.
Exactly.
You'd actually make the tumor grow larger and worsen the hyperthyroidism.
Exactly.
That's why it's so important to really understand what's going on,
Absolutely.
what the root cause of the hyperthyroidism is before you just start throwing treatments at it.
Very important.
This has definitely been a deep dive so far.
It has.
We've gone from anatomy to blood tests to surgery and even tricky medication choices.
It's true. These tumors are full of surprises.
What a wild ride.
But we're not done yet.
Oh, there's more.
There's more to explore.
All right, hit me with it.
Okay, so let's talk genetics.
Yeah, are these tumors hereditary?
Well, most TSH-secreting pituitary adenomas just kind of pop up randomly.
Okay.
But there have been a few rare instances where there seems to be a family connection.
So it's possible for these tumors to run in families?
It's not common, but it does happen.
Okay.
Researchers are still trying to pinpoint the exact genetic mutations that might be involved.
Okay. So if someone has a family history of pituitary tumors or even just thyroid issues, it might be worth getting screened or at least talking to a genetic counselor.
Absolutely. Knowing your family history and sharing that information with your doctor is always valuable.
Yeah, it helps identify potential risks and things like that.
Exactly.
It's all about being proactive.
Speaking of proactive,
Yeah.
research into TSH-secreting pituitary adenomas is always evolving.
That's good.
Scientists are constantly digging deeper, trying to understand these tumors better, refine those diagnostic techniques, and develop better treatments.
That's encouraging. What are some of the most promising areas of research right now?
Well, one exciting area is the development of new medications that can control TSH production better and maybe even shrink the tumor.
Okay.
And they're also exploring gene therapy, which could really revolutionize treatment.
Gene therapy for pituitary tumors. Wow, that sounds pretty futuristic.
It's definitely cutting edge, still in the early stages,
Okay.
but the potential is huge.
Yeah.
And another exciting area is developing non-invasive diagnostic tools.
Ooh, interesting.
Imagine being able to diagnose and monitor these tumors without any surgery,
That would be amazing.
just simple blood tests or imaging scans.
Yeah, it's incredible to think about how far medical science has come.
It really is. It's a testament to human ingenuity.
Yeah, and the constant pursuit of better treatments and cures.
Exactly. As we learn more about these tumors, there's a lot of hope for the future.
That's wonderful to hear.
Yeah.
Well, this has been quite the deep dive. I feel like I've earned an honorary endocrinology degree.
Me too. It's been quite the journey.
But I think we've accomplished our mission. We've given everyone a really thorough understanding of this rare condition.
I hope so. It's definitely a fascinating one.
It is, and so misunderstood, so it's great that we got to talk about it.
Yeah, I think we covered a lot of important points.
We did, from the challenges of diagnosis
Yes.
to the latest treatment options.
And the potential of future research?
Definitely. And most importantly, I think we've emphasized the importance of listening to your body, seeking support, and staying informed.
Couldn't agree more. Knowledge is power.
It is. Well, we've reached the end of our deep dive into TSH-secreting pituitary adenomas. I really hope everyone enjoyed it.
Me too. And as always, we encourage you to keep learning and exploring these topics.
Definitely, if you have any other health concerns, talk to your doctor or do some research.
And don't forget about support groups and online communities.
Yes, finding support can make all the difference.
Absolutely.
And we'll be back soon with another deep dive.
Looking forward to it.
Until then, stay curious, stay informed, and take care of yourselves.